Hi everyone, welcome back to Pre-Health Spotlight's YouTube channel. So today we have a very special guest with us, Dr. Kochanek, who among many other things is the director of the Sapper Center for Resuscitation Research. So thank you so much, Dr. Kochanek, for being with us today.
Pleasure to be with you. I look forward to talking with you.
Yeah, so just to start off kind of at the very basics, I know you went to med school, so what made you interested originally in pursuing medicine?
That's an interesting question. I don't come from a family that anyone had any medical background. My father was a custodian and my mom worked at a Kmart. I grew up in a poor area in Detroit. But I was interested in science, I guess I would say, and in part, some people. I was in a fairly poor high school, and some people said, "Well, they might go into medicine or whatever," and I said, "Well, heck, if they can do it, I can do it," you know.
Yeah.
And I then went to the University of Michigan. And since we weren't very well off, that was, of course, going to a state school, but it was a good state school.
Yeah.
And I did well. I studied really hard, and I applied and got into the University of Chicago, and I also got into Michigan. And in that era, that would have been in 1976. The University of Chicago was one of the top 5 medical schools in the country then, and so I said, I'll go to the University of Chicago. And then at the University of Chicago School of Medicine, I kind of found pediatrics to be one of the most fun things, although I didn't really like outpatient medicine. I liked inpatient, and I liked the ICU and the neonatal ICU. And in that era, there were no intensivists. The chief resident managed the ICU.
Oh.
And in neonatology, it was at the birth of the field of neonatology in that era. And so it was really a pioneering kind of exciting thing. And so it was a nice combination, you know. In one sense, you had cartoons playing on the TV in the room, and kids that have, with the kids, to me, it was like if you're called in at 4 a.m, it's a kid fighting for survival, and I mean, you always felt you could go guns blazing. And that was, and they're resilient. They can come back from amazing badness.
Yeah.
And so, and you hear that now in pediatric ICU, the mortalities are like 1% and 2%. In an adult ICU, it's like 30 or 40%. And so anyway, I think that gives you a sense. So I kind of melded the two. And I was also interested in the brain. I was interested in neurology. And so if you kind of juxtapose the three, it was kind of the idea of neurocritical care in children. And so that's my clinical background.
Yeah. So how did you sort of transition from that towards like research based?
Well, I guess I would say I never really transitioned. I would say I was always interested in research all along. When I was an undergrad, I published several papers in organic chemistry. So I actually have papers in the organic chemistry literature back in the 70s. And so I was always interested in research. And I would say that in critical care, it was a brand new emerging field, and it was almost like everything you did was somewhat of a guess. and there wasn't a lot of published literature. It was really the Wild West, I guess you could say. And so I'll give you an example, and I think it'll really clarify things. Here I was a resident at San Diego Children's Hospital, and I was working with a guy, Brad Peterson, who just recently passed away. And he was one of the pioneer pediatric intensive care specialists. He was super avant-garde. We had ICP monitors, we had EEG, we had people being treated, kids being treated with hypothermia. We had a lot of drowning victims. And so hypoxic brain injury to children who drowned was very common in San Diego. And so how you treat those patients, he had a very aggressive approach. And I then went, after completing my residency, I went to National Children's in Washington, D.C. to do an ICU fellowship. And National Children's was one of the top emerging places to train in the new field of pediatric intensive care. And that was right around 1983. And so I went there, and their main focus was on sepsis and septic shock and multiple organ failure. They weren't really focused on the brain. And I was really interested in the brain. And so I went there, and very few of the patients were on hypothermia, were being continuously ICP monitored or EEG monitored. And I went to the ICU director, and I said, who was a famous guy, Peter Holbrook, and I said, why the difference? He said, well, some of those things that were being done are kind of unproven. They're not illogical, but they're quasi-experimental. We don't have an answer. And I said, well, I want to study that. And he said, well, clinically, there aren't enough patients to do that. In that era, there were no multi-center studies. Everything was done in your own ICU. And I said, I'm ready. He said, well, there's not enough patients. He said, you know what you should do? You should go to the lab. And maybe in laboratory studies, you could come up with some real answers.
Yeah.
And I said, okay, I have some experience working in a lab in organic chemistry. I'm ready. I'll go to the lab. And then he said, we don't have a lab.
Oh.
And so, but I was in Washington, D.C. And so I looked at both the National Institute of Health and the National Naval Hospital, two big research centers sitting right in the middle of Washington, D.C. And in my spare time, for 3 years, I worked with John Hallenbeck, who was a retired guy. He's a very famous guy. He was the chief of neurology at the National Naval Hospital.
Wow.
And he was studying cerebral ischemia in preclinical models. And I called him up and said, I was a fellow in pediatric critical care at DC Children's. I'm interested in neuro. Could I work in his lab with him? And he said, fellows usually don't work out. But if you want to give it a try, this was 1983, you can come here. So I used to work every Sunday when I was a fellow so that I could get Monday off, because you got the day off after being on call for 24 hours. And I'd go to the lab and work with John Hallenbeck on Mondays.
You were really busy.
And now you have the 80, and then the months I wasn't in the ICU, I worked all month. But this way I had not only a continuous involvement, but I also had the months that I was totally free. And I published, I think, 9 papers with John Hallenbeck on novel treatments for cerebral ischemia. And so I then was recruited to Pittsburgh in 1986 to build research, and because I was kind of an anomaly here, I had 9 papers
Yeah.
And shortly thereafter, many of them were on stroke. And because the models that we were using were stroke models. And I was shortly thereafter put on the editorial board of the journal Stroke. And here I was a brand new young attending. And so I was recruited to Pittsburgh to build research in this program in pediatric critical care. It was because it was kind of a new specialty. And Ann Thompson, who now is the dean of the medical school, she's the, I guess, the vice dean for students in the medical school. I think she's like number 2 in command of the medical school.
Yeah.
She hired me in 1986 just to build research. And of course, the attraction to coming here was that there was Peter Safar, course, who invented CPR and was studying all kind of new treatments for resuscitation, and also that this was the birthplace of critical care, and Pittsburgh is the kind of the birthplace of the field of critical care. And so it was an attractive place to be recruited to, and I've never left.
Yeah, that's actually really, it's a lot of different, you did so many different things, but it all kind of culminates into like what you're interested in, which is super cool.
Yeah, it really, the clinical and the research were intimately linked.
Mhm.
What has evolved over time, which is really interesting, is that in the era that I came to Pittsburgh, doing preclinical research was considered the real research.
Oh,
And
really?
clinical research was in its infancy. As I said, there weren't even multi-center studies. So you can only kind of do whatever you can do in your own place. And I say you could never really get a definitive answer. And there were no advanced statistics. There were none of that stuff. And so you did laboratory research and then tried to apply it in your unit, and then maybe other people would do it also.
Mhm.
And but now it's evolved over time that clinical research has gotten really sophisticated. And we have all these multi-center trials, and it's beautiful to see. One of the things that we did that you might, again, getting back to this, how did you get interested in research? And it does all seem to fit together, but we made it fit together, I would say, even more strongly. And that was back in the late 80s and the early 90s. The kids that had severe head injury and the adults at that time point, to this day, they still get treated. A ventriculostomy is placed. So they get a catheter into one of their cerebral ventricles, and we drain spinal fluid to lower the intracranial pressure. And in that era, well, there was no molecular biology yet. You have to remember, the Western blot had not been invented, okay?
Wow, yeah.
The ELISA had just been developed, and there were only like a few ELISAs. If you did anything, you'd measure different chemistries in the brain. But we then, in that spinal fluid, instead of just throwing it out, which is what everyone was doing when it got drained, we measured all kinds of things. And if a patient had to go in for surgery and had to have a craniectomy to relieve the pressure and maybe a damaged portion of brain removed to make more space, instead of just throwing that out or having pathology fix it all in formalin, we did some of the earliest molecular biology studies of it. And so it was really bench to bedside. And one of my trainees, who is now the chief of critical care at Children's, Bob Clark, he did some of the first studies of apoptosis mechanisms in human injured brain and published them in like the FASEB journal. And these were, what was really cool is because everyone in the basic science arena would cite those studies and say, see, this mechanism is operating in the human. So we need to study it in the mouse, or we need to study it in the rat, or we need to study it in cell culture because it's happening in the human. And so I think that gives you an idea that also really kind of energizes your trainees because, hey, the patient I'm working on, The same thing is happening in them as in the lab, and we're putting it on the map. And so though in that era, and to a large extent still, because brain injury is so complicated, we didn't have like a magic bullet treatment. We still, and to this day, have been really trying to understand the evolution of damage from bench to bedside. And so that's really how it all fits together.
Yeah, no, that makes a lot of sense actually. So, kind of going back to what we were saying about Pittsburgh being like the birthplace of critical care medicine, could you talk a little bit about sort of the history of the Saffer Center? Because I'm not sure everyone watching knows, and then also what your role as director entails.
Yeah, that's a really, really interesting question. And for those of you who didn't know Peter Saffer, Peter was an important figure in medicine in the world. And he came to Pitt from Baltimore City Hospital, which was just a little satellite hospital of Johns Hopkins. And it was at Baltimore City Hospital that he and his colleagues paralyzed each other with curare to prove that mouth-to-mouth resuscitation was effective. And he published all of those studies in the New England Journal and JAMA. And I mean, it was pioneering work. Of course, IRB wasn't that important in this would have been about 1956. And but then he was recruited to Pitt, and he came to Pitt and was the chair of anesthesiology from 1960 to around 1979. And in that era, he revolutionized the Pitt Medical Center. My recollection is that when he came here, there was one anesthesiologist at Presby, one at Children's, and one at McGee, and all anesthesia was done, supervised by them with nurse anesthetists. So it wasn't academic at all. It was really a service. And there was no emergency medicine, and there was no intensive care. Okay. So Peter Saffer came, and the way I would describe it, he revolutionized acute medicine at Pitt. And he hired something when he was done, he had 200 anesthesia faculty.
Yeah, wow.
Okay. And just to give you some idea. And he is one of the three fathers of critical care in the US. And so he's the program at Presby is the oldest training program, fellowship training program in critical care anywhere. It is, you could say, Mecca, you know, and it's pretty cool. And but he did way more than that. He really spurred the idea of emergency medicine, because what happened for many years was somebody from anesthesia, when a really sick patient was admitted, would just go to the emergency room. And that was true here at Children's, and even when I started. And at Presby, and then they'd take the patient up to the ICU. And it was really anesthesia that served that role. They were acute medicine. Of course, they could manage the airways, the central catheters, arterial catheters, physiology, blood gases, you know, airway management, etc., mechanical ventilation. It was all done by anesthesia. And then the field of critical care evolved out of that. The other thing that Peter Saffer did was that he set up the first ambulance service, and he created the field of paramedics. And one of his fellows, Nancy Carolyn, again, this was all in the 60s and early 70s, set up a project called the Freedom House Project that were the first paramedics. And it revolutionized pre-hospital care. And this was all Peter Saffer doing this all at once. In 1979, he stepped down as the chair of anesthesia. And in 1980, the chancellor of the university gave him a building that was on the main campus. It's called the Hill Building. And initially, the entire second floor of that was was called the International Resuscitation Research Center, or the IRRC. And Peter Safar operated there and set up the first, if you want to call it, preclinical and translational research program in resuscitation. And that in 1994, he stepped down and I took over as the director of the center. There was a competition and several people were asked to write what you would do with the center. And I did, and somehow I won it. And that was 1994. And I've been the director since. My first act was to rename it the Safar Center.
That's a good first thing.
It was a really good first move. And but of course, Peter Safar was around for almost 10 more years. He passed away in 2003. And but I've been the director since 1994, and it seems like a couple of weeks.
Really?
Yeah. But the program too has evolved greatly from focused just on resuscitation, although Peter had an interest in shock also, hemorrhagic shock, for instance, and in disasters. He had an interest. He wanted to apply CPR to resuscitation to anyone who needed it, even if it was a mass disaster. How do you handle it? And but in my interests, we expanded it. We put a little bit more of a pediatric interest in it. We really added traumatic brain injury to the portfolio. We also brought in neurosurgery, physical medicine, and rehab. We're kind of interested in resuscitation, I always say in its broadest sense, from the field to rehab. We then also I was able to get 21 years ago, a T32 training grant, training in pediatric neurointensive care and resuscitation research that funds 4 trainees every year, and from National Institute of Child Health. And we just got it renewed, so it will be at least out to 26 years. And it's trained a lot of people that are now at all kind of institutions all over the country. And so that gives you a little bit of an idea of the Safar Center. And the Safar Center right now, as I said, is very it's unusual in that, in this era, people have, I call it, have kind of gotten trapped into bean counting. Do I have, everything's single department, there's less collaboration. That might be inaccurate. There's still a lot of collaboration, but actually having people from multiple departments in one center is unusual. You might collaborate, but it's center here, center there, da, 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 da. In contrast, we have the people all from multiple departments in our center. And so that's a very cool thing. And we have people studying either traumatic brain injury or cardiac arrest in adults, in pediatric models, in cell culture, in patients. And we have as many preclinical studies as we have clinical studies. Our portfolios, if you look at our publications, they're pretty balanced. It's about half and half. And if anything, in the last 5 years, we probably went from 60-40 preclinical clinical to 40-60 preclinical clinical. And that's true of both publications and funding. And so that trying to give you a little bit of an idea. We are here in Rangos. We were on that main campus in the Hill building up until about 5 years ago. And then that building started to get pretty old. And I think some space opened up here at Children's in the Rangos Research Center. And they built us, the university built us an amazing custom built research facility that is pretty unique.
Yeah.
And so that's given us really nice preclinical facilities to do what we do. And then we're linked to both the children's clinical operation in the ICU and the Presby. And we have, just so that your audience knows, we have specific neurocritical care programs to train you to be a board certified neurocritical care expert, whether you're an adult at Presby or whether you're at Children's. And the pediatric neurocritical care board certified training is really uncommon. There are only about 3 or so in the country. And yeah, just to give you some idea. And many have called us, or me, you could actually say, kind of the father of pediatric neurocritical care. But it's a little bit more complicated because, like I mentioned, there were people doing some of these really novel things. Several of my mentors, certainly my mentor in San Diego, and they didn't call it pediatric neurocritical care. They just did whatever they needed to do to try to pull the kid through, you know?
Yeah.
And but it's a very cool thing here in Pittsburgh. And I would say neurocritical care is really a premier thing in Pittsburgh, as is all of critical care.
Yeah, I definitely agree with what you're saying about like the collaboration in the Saffer Center, because I remember when we had the Saffer Student Day Symposium, it was so similar and like intertwined, but also a lot of different topics. And like you said, like cardiac arrest, like my research was on traumatic brain injury, but then listening to people talk about cardiac arrest and like a similar model, it was really cool to see all that kind of how it intertwines.
Yeah, you know, you raised something really interesting. It's exciting to hear someone young saying it's cool, because in my mind, it is cool, but it's also powerful.
Yeah.
Because if you understand, take a acute brain injury. At the two spectrums, you have trauma and you have ischemia. And there are all these different forms of ischemia. You could have a stroke, you can have a cardiac arrest and have no blood flow to your brain. You can overdose and have an asphyxial episode where you're hypoxic and then you have an arrest. You can have an intracranial hemorrhage, a subarachnoid hemorrhage. All of these land you in the neuro ICU. And in traumatic brain injury, you can have a concussion, you can have a contusion, you can be a shaken baby and have a shaken baby brain injury. And then there's some others. Of course, you can have meningitis or encephalitis and have a CNS infection. And although we're not studying that, those two components, trauma and ischemia, are just centerpiece common diseases. They're the bread and butter of neurocritical care. And to have clinical and preclinical card-carrying NIH funded, Department of Defense funded investigators working on them in the same place causes a lot of interplay and synergy. And I think that even our journal club, you probably understand acute brain injury better because of you're not just focused on one disease.
Yeah, I would definitely agree with that. I know you're involved in a lot of different research projects. Do you want to highlight any of them and give like a little summary for anyone who's interested in maybe resuscitation or traumatic brain injury research?
Yeah, and what I'm working on is just a tip of the iceberg. Also, maybe I'll say a couple of things about a couple of even broader projects in the Saffer Center. Myself, I would say my main areas are probably three areas. One is we have forever been interested in the use of hypothermia to treat acute brain injury. It's one of the most powerful therapies. It's tricky because I always say it's not a pill. It's a complicated thing that you have to cool a patient or whatever. It is utterly standard of care. You must use it in a newborn, a term newborn that has a hypoxic brain injury that meets a certain level of injury, you have to use it. You do 72 hours of cooling. In older children or adults, it's much more controversial. It turns out there are probably some mechanisms in the infant brain that are particularly benefit from cooling. The delayed neuronal death mechanisms, for instance, seem to be really ready to rumble in the infant brain, and they get blocked by cooling. And so you improve outcome. But we're working on ways to try to make hypothermia work better. And not just ways that are like how long or how deep, whatever, do you cool or no, we're interested in molecular adjuncts to hypothermia. And we've been studying cold shock proteins and their receptors in the brain, that there are certain drugs that might be able to make hypothermia way more powerful. And ultimately, we'd like to, what we call, have hypothermia in a syringe, where you could figure out what mechanisms are being beneficially affected by hypothermia and just give an injection of a blocker of those bad guys.
Yeah.
So that's one area. A second area that we're really working on, and you can look at some of our recent publications, is on new ways to block brain swelling. And cerebral edema, as you know, is one of the things, the key thing that we treat in the neuro ICU. If patients with acute brain injury come in, they get an intracranial pressure monitor, and we do all kinds of things to try to limit swelling in the brain. And we've been studying several molecular pathways that are triggered, because our goal right now, the way we treat brain swelling is brain swelling happens and we give drugs to dry out the brain, if you want to think of it that way. Either drain fluid or give things like osmolar therapy that, in essence, pull fluid out of the brain, and then it increases your urine output. And so you get rid of that fluid. But we would like to develop, and we've got some real promising strategies. We'd like to develop therapies that are a preemptive strike, so that we get them on board and it prevents the edema from ever developing. And we've been working in collaboration with an investigator at the University of Maryland, Mark Samard, who, and I'm now working also with an investigator at the Barrow Institute in Phoenix, Ruchira Jha. And we've been looking at a novel treatment to try to block that, and also the genetics of the ion channels involved, so that we might predict which patients are really going to swell, because some swell more than others. So that's a second area. And then the third area that I'm interested in, I for many years have led what's called Operation Brain Trauma Therapy. It's a multi-center preclinical drug screening consortium funded by the United States Department of Defense. And we've tested 12 different therapies across 3 models at multiple centers across the US. And we also test biomarkers of brain injury, serum biomarkers. Can we tell how badly the brain is injured from a blood test? And can we tell if a drug is improving it? And you may or may not know, in concussion, 2 biomarkers, GFAP and ECHL1, were just approved.
They were approved?
Yes, they were approved.
Oh.
And but what's cool is that Operation Brain Trauma Therapies data were part of the FDA package that helped get them to approval. And so that's testing new therapies in a multi-center preclinical strategy is one of the other areas. We've got a couple of other really exciting, there are many. You saw the stem cell therapy presentation in traumatic brain injury by Anthony Klein's group. And Julia Bayer and her group, they're just doing blockbuster stuff you may or may not know that the mitochondria have a unique lipid, cardiolipin. It's only found in mitochondria.
Oh, really?
And it turns out that it gets oxidized in a very non-random, very select enzymatic way after reperfusion and in traumatic brain injury too. And they have been not only developing, and it triggers a cell death pathway called ferroptosis. And they have been like world leaders in publishing in, as I was saying, Nature and in Nature Neuroscience and Cell, and I mean all these big top tier journals on new therapies to try to prevent that. And they've got some evidence it's happening in the human brain. And they also have been developing biomarkers that leak out of the injured mitochondria in the brain into the circulation. And because the brain's cardiolipin is truly specific, they can say that molecule came from a brain mitochondria. And so it's not just this is a brain biomarker, but it's a brain mitochondria damage biomarker. Wow. And so if you have a drug now that you're targeting to prevent the mitochondria, you can now say, did it attenuate the damage to brain mitochondria just by doing a blood test? And so they've got some really exciting stuff with that. There are a host of other people. There's a lot of work on inflammation by different groups. There's also a lot of work on the synapse. Ed Dixon and Sean Carlson, and there's also quite a bit of investigation on, I would call it, neurotransmitter replacement. Anthony Klein, Amy Wagner, Ed Dixon, things like during the rehab phase, what medications can you give to enhance neurotransmitter function and then make rehab more effective?
Yeah.
And that's one of the cool things also about this place. Yes, we have all these ICU related and acute things, but we also have these rehab guys mm-hmm. that are taking the preclinical models and extending them out and testing rehab strategies, and they're the same ones they're using in patients, and so that's very uncommon also. So that gives you a little bit of an idea, and we have a lot of trainees, as you saw.
Yeah, for sure. That's really interesting. I think that really shows kind of the diversity of all the projects. I also didn't know that GFAP got approved because I remember reading, I think it was like the track TBI study paper, and they were like talking about the results, but I didn't know that it got approved.
Yeah, GFAP and UCHL1 a little while back were approved and they are actually approved in the setting to make the diagnosis of concussion. And right now they're working on a point of care device, so that like in the emergency room, or maybe even like on the field, if you were a football player or something, and did this person have a concussion, you just do a blood test and it says, oh, it's off the charts. Yeah, you're out. That would really be cool. Yeah, and that would really be cool. Our interest in biomarkers is maybe even a little bit more nuanced, and that is we'd like to be able to use them as what the FDA would call a pharmacodynamic response marker. So if we give a therapy, will it bring the level down? And would it do that in a preclinical model? Would we be able to do it in a human? And so that's one of our areas that a lot of people here are working on and or use.
Okay, cool. And then I guess, so having said about all of these amazing research opportunities, my last question would be for the undergraduate audience watching, how can they become involved in all of these really cool labs?
Well, I think that there are, I guess I would put it, there's a lot of entryways into this. Probably the most successful has been what you did, and that is in one of the summer student programs, either through the Center for Neuroscience or Children's Hospital has a summer research program that you can apply for. You have to be ahead of the game, though. I think you have to apply like in the late fall or something like that. You'd have to look on these various websites. And we also, for a number of years, it's just ending, but we may be trying to rekindle it. We had a cure program for underrepresented minority students also to get involved in our traumatic brain injury program. So I think Pitt has a lot of potential summer student opportunities. Oftentimes, that can serve two purposes. One is getting you into a lab, getting to meet a mentor. If they find, hey, you're a good student. We people here are so supportive, I think, and excited by young minds, because you guys are smarter than we are, and you have all the new ideas and everything. And then all of a sudden, it's like, well, why don't you stay and work during your semester, maybe do an elective that has a lab elective, and or come back next year too, et cetera, et cetera. So that often happens. Even if it doesn't, if you've done a good job and you've enjoyed it, you have no idea how many recommendations I write for trainees, and in my case, obviously, I have fellows, I have young junior faculty, so it's more than just students. But the other thing is that entering in that way, you can find oftentimes there's lists of who the possible mentors are, and you can look through and see what they're working on. And if and many times too, I'm much more apt if a student directly emails me, I will hook them up with some of our younger investigators who really have the time, as you saw in the summer research program, to spend the time with you guys, and on a one-on-one kind of exposure, because I think the assistant professor level, maybe associate professor level faculty are perfect for trainees, and so that's my sense of it. As you saw, these summer students were funded by a variety of mechanisms. It wasn't just like there was one entry point. And I think that's really valuable, because there's a lot of different opportunities. But you have to apply. You have to talk to a potential mentor. You could come by, and people can give you a tour or whatever, but getting the funding in advance is really essential.
Yeah, I think I would also definitely recommend Sappher. I think everyone was really supportive there. I also liked how we had journal clubs, and we even had one for our own lab too. So we had a separate Dixon Carlson journal club, and we got to talk about stuff. And then we had the entire Sappher journal club, which was also very interesting to see everyone else's papers. So yeah, I think just applying, that's how I did mine. And I think even if you email some of the associate professors, like you said, they're all very welcoming and very supportive.
Yeah, no, I think, we were all in your shoes at one point.
Yeah.
And even though we didn't have ripped up pants and these kind of things, we still can relate to you guys.
Yes. Okay. Well, thank you so much for your time, Dr. Kochanek. And I hope this was helpful to anybody watching. And there's also going to be a link in the description for another really cool video that UPMC shot about Sappher and kind of Sappher Center's research and all of that, also featuring Dr. Kochanek in it, if you want to see more of him. So that's also going to be linked in the description box. But yeah, I hope this was helpful for anybody watching. Thank you again, Dr. Kochanek.
Thank you. And it was really a pleasure. And I'm really pleased that you had a good experience.
Thank you.
All right. Hope we see you back.
Thanks.
All right.